Здравствуйте. It's my pleasure to speak to you today on the management of hepatitis C and HIV and go through some of the new data we have with regard to management of hepatitis C and HIV. Now, if you look at the first slide, which shows the Europe map, you easily can see that the prevalence of hepatitis C in the HIV population concerns around 1/3 of patients, clearly with higher rates of hepatitis C co-infection in Eastern Europe, amounting almost 50%, also higher in Southern Europe, and then lower in North and Middle Europe. And clearly, I think we all agree the burden of co-infection is high and will be the biggest clinical challenge, particularly in the Eastern European country. In the next slide, you can see the distribution of hepatitis C genotypes in the EuroCETA cohort, really showing that the difficult to treat genotype 1 in almost 50 to 60% of patients is the most prominent genotype, but you can also see that particularly in Eastern Europe, genotype 4, also difficult to treat, is another genotype of importance, and then very little genotype 2, and then a lot of genotype 3. If you look at the overall number of patients, you can see that 3/4, 74%, have signs of ongoing viral replication as a sign of chronic hepatitis C, which means that you first will always have to check in a patient whether he has spontaneously resolved infection, which can occur in 25%. Since most of these patients still acquired hepatitis C prior to HIV, this is probably a more positive outlook. Patients who get hepatitis C after HIV have a lower likelihood of spontaneous clearance and are to over 80% likely to develop chronic infection. In the next slide, you can see the progression to cirrhosis in different patient cohorts from France, and you will easily see that patients who have HIV and hepatitis C are the ones who at youngest age have the highest risk for progressing to cirrhosis, underlining that there is a more unfavorable course of hepatitis C in HIV-infected patients, and this is true over all other origins of liver disease in this large cohort of patients from a French outpatient clinic treating patients with liver disease. The next slide, you can see that in parallel to the decline in AIDS-associated mortality in red and decline in yellow in overall mortality, subsequently, comorbidities have become clinically more relevant, and clearly mortality due to liver disease has increased as HIV itself has become treatable, highlighting again that hepatitis C co-infection is probably the most challenging clinical complication in patients who have hepatitis co-infection. In the next slide, I've outlined for you the issues I want to talk about today: treatment of chronic hepatitis C, addressing access to treatment, dosages and duration of interferon ribavirin, genetic factors which may impact response rates, what is the role of HIV-associated immunodeficiency on treatment outcome, what is the best HIV therapy to give with hepatitis C therapy, and what are the challenges in treatment of hepatitis C with the new oral agents as they become available. In the next slide, you see the current and cumulative exposure to anti-hepatitis C treatment in EuroCETA, and you can see that overall in Europe, less or around 25% of patients have ever been treated for their hepatitis C, suggesting that 75% have not received treatment, and that can be either because there was no sign of progressive liver disease warranting therapy, could be that there was cost-wise restraints and that's why no therapy was offered, or it could be contraindications to side effects of interferon and ribavirin. But clearly, the majority of patients so far have not been treated, highlighting that there is a big need in this area. The next slide is an important slide. In these studies, as well as many others, it has been very elegantly shown that in those patients who are treated with interferon and ribavirin, subsequently they remain very unlikely to develop complications for liver disease, even if they were included with cirrhosis upon treatment. So you can see that patients who developed what we call SVR, sustained virologic response, a negative hepatitis C PCR 24 weeks after treatment, there is no new occurrence of a liver disease relevant event, whereas patients who have no SVR, you can see survival decreases over time due to the occurrence of further events in the course of progressive liver disease. So really highlighting that if you treat someone successfully, you immediately significantly improve his further prognosis. The next slide, you see in a table the summary of all the different treatment trials with pegylated interferon and ribavirin, and if you concentrate on the bottom line, you can see that cure rates range between 27 and 50%. So there was some substantial differences. Now the patient population studies were somewhat different, partially explaining some of the differences. So please note that patients with cirrhosis were higher in some trials and lower in others. And also the genotype distribution was not similar, so that might have had an impact. But I think it's also important to highlight that in the first 3 studies with the lower response rates, we used a lower ribavirin dosage, only 800 milligrams as a fixed dose because of the fear of drug-drug interactions, and that may partially at least explain why the results were not that favorable. In the next slide, you can see the current treatment algorithm for hepatitis C in co-infected individuals, which comes from the European guidelines. So in someone who has elevated liver enzymes, sign of chronic viral replication, you would recommend treatment with pegylated interferon and ribavirin. If that patient is negative at week 4, he is a rapid virologic responder, and then you would only require 24 weeks of therapy for genotype 2-3 and 48 weeks of therapy for genotype 1-4. I have to say, though, that this is a very rare event, probably less than 10% of patients. If you are positive, therapy is continued, but you should at least show a 2-log drop in hepatitis C RNA at week 12. If that is not the case, well, then there's no chance of response and therapy can be disrupted. If patients do show that 2-log drop, they still have a good chance of treatment response and are continued but should be negative at week 24. If that's the case, then patients with genotype 2-3 should be treated for 48 weeks and genotype 1-4 for 72 weeks. So it's an individualized response-guided recommendation and clearly means that we on average treat our patients much longer than in mono infection. In the next slide, you can see some of the recent work on the importance of host factors on treatment outcome. And you can see here that in patients who have hepatitis C infection and no HIV, on the very right figure, there's a strong correlation between the CC-IL-28B genotype and cure rate, which is significantly pronounced, over 60% in those patients with the CC allele, whereas patients who have CT or TT have a much less chance of cure. The same association is found in HIV-positive patients with chronic hepatitis C, and it's only not found in patients with acute hepatitis C, most likely because in acute hepatitis C, overall cure rates are so much better altogether. I think what we have learned, and that is shown in the next slide, is that the amount or how the CD4 count is or how good the immune system of the co-infected patient is important. So patients who have the highest quartile of CD4 count, relative percentage of CD4 count, have a much higher rate of SVR or cure for hepatitis C than those with the lower CD4 count percentages, clearly highlighting that patients at best should have a good CD4 count when they enter hepatitis C therapy and most likely should start HIV therapy prior to giving hepatitis C therapy. Now, in the next slides, let's look a little bit at some of the important drug-drug combinations, which drugs can be safely administered for treatment of HIV and hepatitis C. I think it's important to underline that ribavirin causes hemolytic anemia. Therefore, obviously, AZT is not a good choice as it can pronounce anemia as well. D4T and DDI have been associated with a lot of toxicity, higher risk for lactic acidosis, hepatic decompensation, weight loss, and are therefore not recommended. DDI is clearly contraindicated. And then there has been some discussion around abacavir use and lower SVR rates, but this was only shown in trials with a very low ribavirin dose of 800 milligram, and this was not shown in other trials where they used a body weight adapted ribavirin dose. Interestingly, in the next slide, you can see the results of a recent poster presentation which just appeared in Journal of Antimicrobial Chemotherapy, a meta-analysis of 1,700 patients receiving PEG and RIBA. And what they did is they looked at all the different nuke backbones to see whether there was a combination which impact on cure rates, and only AZT3TC were associated with lower SVR rates, most likely because AZT causes anemia, ribavirin causes anemia, and there were more dose reductions of ribavirin and interferon because of the hematologic complications through AZT. All other regimens, including abacavir, did not have an impact, so it seems to be safe to co-administer either abacavir or tenofovir with either 3TC or FTC and PEG and RIBA therapy. The next slide is data from an own German study in which we looked at hepatitis C mono-infected patients versus co-infected patients, and these co-infected patients were three groups: those who had a great CD4 count and required no HIV therapy, and then those co-infected individuals who had an indication for therapy, and they were randomized to nuke-containing or nuke-free heart. You can see that overall 54% of patients with hepatitis C monoinfection were cured, and also 54% of patients with co-infection. So really saying there's no reason not to treat HIV patients, as overall in this compared trial, response rates were very similar. And you can see that actually the nuke-free regimen did very well, so a protease integrase combination, for example, might be a feasible option. The numbers are small, so I think we can't draw too much conclusions from this, but clearly nuke-free regimens could become a possible combination partner in hepatitis C therapy in the future. I think it's important in the setting of limited resources, not everyone qualifies for PEG and RIBA, to remember that if patients receive HIV therapy, this will also have an effect on liver fibrosis progression, as most liver disease-related events occur in patients with advanced immunodeficiency. It made some sense to look whether initiation of potent HIV therapy could reverse some of that fibrosis progression, and you can see here on the right-hand side that indeed patients who received HAART had a much more favorable survival outcome than patients with monotherapy or double nuke therapy or no therapy at all with regard to liver-related disease events, really highlighting that HIV therapy can also be protective and slow down liver fibrosis, which I think is always important, as you will not be able to treat everyone, and then at least we have a chance of using correspondingly HIV therapy to prevent liver fibrosis progression. Now on the next slide, we're moving on to some of the recent advents in hepatitis C therapy, and clearly we're all excited if these drugs become affordable and we can use them in clinical practice, but there's some general things we might want to consider. First, hepatitis C and HIV co-infected patients have higher hepatitis C viral loads. That means they may be less likely to respond, may have a higher risk for resistance development, and then the first available hepatitis C protease inhibitors are metabolized by the cytochrome P450 system just as well as our HIV drugs, so there may be significant drug-drug interactions, and then because they also have shown quite some toxicities in monoinfected trials, there could be a risk for overlapping drug toxicities. The next slide, in a sort of a cartoon drawing, just tries to reiterate or underline that in the setting where we give an hepatitis C compound, which is not fully suppressive, that there is a risk for selection of mutations. It is believed that many mutations are already present prior to starting hepatitis C therapy, which is a reflection of the high viral turnover, high replication rate, and the high mutations, number of mutations which occur because of mistakes during the replication process. And so if there is ongoing replication, these pre-existing mutations will be selected and enriched under drug pressure. In the next slide, you can see results from one of the very early telaprevir monotherapy studies, where indeed after 14 days in patients who were not completely suppressed or developed a breakthrough, you can see a development of significant resistance, really highlighting that there's a low genetic barrier and a very early on high resistance risk. Now let's move on to some of the first results from trials with the new hepatitis C protease inhibitors in co-infected patients. You see here the study design of the Telaprevir study, study 110, which really had two arms. Patients with very good CD4 counts were randomized to part A, no ART indication, and there they were randomized either to Telaprevir, PEG, and RIBA for 12 weeks and then continued PEG, RIBA for another 36 weeks, or it was placebo, PEG, and RIBA for the first 12 weeks and then just PEG and RIBA for the another 36 weeks. For those patients who had an HIV therapy indication, it was either an ATRIPLA-like regimen with efavirenz, tenofovir, FTC, or boosted atazanavir with either tenofovir, FTC, or tenofovir 3TC. The next slide shows you the week 12 data, and you can see that there's a significant difference between patients who receive Telaprevir in addition to PEG and RIBA, with around, over all three arms, around 70% of patients responding. At the AASLD meeting just a couple of weeks ago, the 24-week results were shown, again showing 70% being undetectable under Telaprevir, PEG and RIBA, and that is then already 12 weeks after stopping Telaprevir, and by then, though, the PEG-RIBA arm had catched up with around 50% of patients being undetectable, but clearly much better response rates in the triple arm. In the next slide, you see the serious events and treatment discontinuations listed, which is obviously important as we had a fear of more complications in this challenging patient population, but particularly rash, which is one of the more worrisome concerns under Telaprevir treatment, was, though higher, it did not lead to discontinuation. So we had a higher prevalence of rashes with Telaprevir treated patients, but not discontinuations, and that was sort of reassuring. There was some anemia, but otherwise a very well tolerated regimen. The next slide, I have summarized for you the drug interactions with raltegravir. There seems to be an increase in raltegravir levels by 31%, looking at the AUC, but otherwise little interaction, so Telaprevir levels remain the same, and the two can be safely co-administered. Clearly, raltegravir will play an important role in co-infection treatment, as it is not metabolized by the cytochrome P450 system, and therefore appears to be one of the best choices when treating co-infected patients with hepatitis C therapy. Telaprevir and efavirenz is associated with significant interactions, and that is why an increased Telaprevir dose needs to be given. So instead of 2 tablets 3 times daily, you increase to 3 tablets 3 times daily in combination with efavirenz, which is not completely unproblematic, as you obviously then also substantially increase price, which already is very high. Moving on to the next slide, some of the PK interaction data with Telaprevir and commonly used protease inhibitors for treatment of HIV, and you can see significant reductions in Telaprevir levels of over 50% with lopinavir, making it an absolute contraindication. The fear is that you will not have sufficient Telaprevir levels to control replication. The lowest interaction occurs with atazanavir, and that was why atazanavir was chosen for the corresponding pilot trial. In the next slide, you can see the interaction from Telaprevir on the level of the corresponding HIV protease inhibitor, and you can see that with darunavir and fosmanogeprenavir, you have significant reductions between 40 and 50%, and again, in a patient who needs levels to suppress HIV replication, this would obviously not be a good combination to use. So the only PI which is currently recommended in conjunction with Telaprevir therapy is boosted atazanavir, but you do see in blue that patients who receive boosted atazanavir and Telaprevir have somewhat higher atazanavir levels and therefore a higher risk for hyperbilirubinemia, which could become a problem over time. Now let's move to the next slides, which are taken from the recent presentation of the interim results from the boceprevir trial. So this is the second licensed hepatitis C protease inhibitor, which was used or studied in the very traditional way, a lead-in of 4 weeks PEG and RIBA, and then patients received either placebo PEG and RIBA for another 44 weeks or boceprevir PEG RIBA as triple therapy for 44 weeks. Please note that in this study, as well as in the previous one I showed you, there is no individualized treatment duration arm with shorter treatment periods. You know that in mono-infected patients, patients who get negative at week 4 can also be treated with shorter durations, or with regard to boceprevir, who are negative at week 8 and 12. But this obviously it was not studied in these 2 trials. If you look at the use of antiviral therapy, you can see that there was a much wider range of protease inhibitors used. Remember, in the telaprevir study, it was only boosted atazanavir. Here you also have quite a number of patients on lopinavir or darunavir, and you also have patients included who were on integrase inhibitors or CCR5 antagonists. So it looks as if there's more combination possibilities. Looking at the response rates, again, also for week 24, you can see that 70.5% undetectability is an excellent result, and clearly superior for the triple therapy over standard of PEG and RIBA was only 34%. Clearly a substantial benefit of adding the hepatitis C protease inhibitor. And let me just remind you again, this is all in genotype 1 patients, as the new drugs only work in genotype 1. Moving on to the next slide, looking at hematologic adverse events, I think it's important to note that there were not too much more hematologic side effects with boceprevir-treated patients, which is sort of surprising, as that was the leading side effect in monoinfected patients. But you can see that indeed we're doing not too bad here at all, and the use of erythropoietin overall, only 20 to 27%, was first of all comparable between the 2 groups and not that different. Now, about the drug-drug interactions, we move to the next slide. It's important to highlight that one of the very few significant interactions is between boceprevir. Before we come to that one, if we look at the boceprevir-ritonavir interaction, there seems to be very little interaction, and that is why boosted protease inhibitor trial, you can see there are subtle changes in Cmax, which is somewhat lower, AUC is somewhat lower, Cmin is almost unchanged, but this was felt to be so little that it would be expected to have no impact. But in the next slide, you see the more significant interaction between efavirenz and boceprevir, with a reduction of over 50% in boceprevir levels, and that is at least considered to be potentially of concern. But in the next slide, you can see data from the monoinfection trials where they looked at different quartiles of boceprevir levels, and there was no association between lowest level and SVR rates. So regardless whether you had a high or low level, your chances of cure were pretty much the same. So it's unclear whether you, if you could use that, and even the presence of a lower level would still have a chance of better response rate. So for now, I think if possible, other combinations should be preferred. Coming to the end, in the next 2 slides, I just want to give you some practical guidance of how to manage patients. So if you have someone who's co-infected with a genotype 1, I think it's important to do fibrosis stage assessment, because that gives you something or an idea of the urgency of how to treat the patient. So if he has absolutely no signs of fibrosis, well then potentially treatment with PEG and RIBA alone could be done if there is a low viral load, he has a favorable IL-28B genotype, then he probably will respond just as well just with PEG and RIBA. If the patient has more advanced fibrosis stages, that is where the benefit of triple therapy really kicks in. And if he has an F4 fibrosis, well then this can only be done in specialized centers because the risk of complications is very high. If we move to the last slide, or the one before the last slide, looking at treatment history. So if you have been a relapser to previous interferon ribavirin, well then you are the one who already has shown sensitivity to interferon, was just not good enough to cure completely. Those are the patients who probably have the best benefit from triple therapy. Those who are classic non-responders, less than 2 log drop under interferon ribavirin, they are not that likely to respond to triple therapy, so you would rather defer in early fibrosis stages and only treat where you have no other choice, and the naive patients we have talked through. So in the last slide, I'm just summarizing pretty much the most important messages from this talk. The first is that co-infected patients have a more unfavorable outcome of liver disease, show a faster progression to cirrhosis, and have a higher risk of dying from liver disease-related complications. If you are stuck with interferon and ribavirin, I think it's important to use the body weight adapted ribavirin dosage and to do an individualized treatment duration based on how fast you respond to therapy. Clearly, HIV therapy is very beneficial in co-infected patients, and that's why in most guidelines that is recommended to be even used earlier than in other patient groups. I think that the new oral hepatitis C drugs are very promising. There are obviously quite some cost issues, and the drugs have not been implemented into all countries yet because of ongoing price negotiations. Clearly, triple therapy can be used and has an advantage, particularly in more advanced fibrosis stages, in relapsers, and I think it should be used in practical terms with regard to the algorithms I tried to show you. So thank you for listening.
Итак, уважаемые коллеги, спасибо профессору Рокштро за его прекрасную презентацию. Сейчас мы будем действовать вот по какому принципу. Professor Rockstroh, there is one question in the questions area. It is already translated, so if you want to go there and read it, whatever is there in English.
I don't see anything in English. I see Olesia.
There's public chat, user list, and questions.
Oh, yeah.
No, there is another tab
here,
that says questions. Click on that.
Yeah, I've been to that one. Okay. There are many questions.
Okay.
Ooh, let me start with the last
one. So it is translated. Yes, so if you can just read it.
Okay. Is it at all possible to administer hepatitis C therapy in this group of patients together with ongoing seasonal course of TB therapy with the patient receiving optimal heart with good account of HIV, hepatitis, and TB drug interactions? Well, I think if someone has tuberculosis, you would first treat tuberculosis because obviously interferon is immunosuppressive and you would just worsen the TB course. So always give TB therapy first, treat that complication, and once you're done with that, then you can think about treating hepatitis C. Other question. Well, let me go up to the top. The first question is here. We have a lot of patients with HIV, hepatitis C, TBC co-infections, up to 98% with HIV and TB in Krasnoyarsk have active hepatitis C. They did not get prior therapy for hepatitis C and have a serious CD4 suppression and active TB. The high mortality in this group is often due to HIV and TB progression. However, some patients can be rehabilitated for HIV and TB, and we see that hepatitis C retains its virologic activity, and there's a lot of hepatotoxicity on TB therapy in heart, aggravated by active T. Oh, and then it comes, do you give antiviral therapy? No. So you first thing would be to start TB therapy, then give HIV therapy because that's obviously important also for the outcome of TB therapy. And then once you've got finished with your TB, then you can think about treating hepatitis C. But I agree, in patients, particularly if they have more advanced liver disease, administering TB therapy can be very challenging, and liver enzyme rises are very frequent, and it can be quite some difficulties to get the patient through the TB therapy because of liver issues. But we would never treat hepatitis C at the same time as TB.
Okay, so I guess there are a couple more questions if you go up in the question list, Jürgen?
No, but that's all. It's all about the TB thing. That was all one question.
Okay, so it's all one question.
Yeah, it's all. It's first describes
Great.
just the higher TB rate
Mhm.
and HIV hepatitis C, which is true, and so forth. But it was one question that is, can you give it all together? No, you have to do hepatitis C after starting
Okay.
HIV therapy and treating TB.
Okay. Yes. Okay. Уважаемые коллеги, есть ли еще какие-нибудь вопросы к нашему уважаемому профессору Рокштро? Потому что если нет, то мы сейчас будем заканчивать нашу сессию. Okay, Jürgen, I think that we're done with the questions.
Okay.
So let me just see if there's anything else. Just one moment.
Okay.
So if there is anything else. Okay, so what we're going to do is we will finish here, and then we will have the rest or your answers translated into Russian for our listeners and distributed later. And
Okay.
let me just say the same thing in Russian. Так, уважаемые коллеги, те ответы, которые профессор Рокштро сейчас дал на английском языке, будут переведены, и тогда же, когда будет выложена презентация данного вебинара, там же будут выложены и ответы профессора Рокштро на русском языке. Я думаю, что это будет сделано в ближайшие 2 дня. Поэтому спасибо уважаемому профессору Рокштро, спасибо вам за участие, и я надеюсь, что мы с вами еще увидимся на следующих вебинарах. Если нет никаких вопросов, то тогда мы будем заканчивать нашу сегодняшнюю сессию. Okay, so thank you, Jürgen, and hopefully we'll see you again.
All right.
It
Thank
was a
you.
great presentation.
Okay. Well,
And
thank you, and have
maybe
a
we'll do it
wonderful
again
Christmas.
next time.
All right.
Okay. Thank you a lot.
До свидания.
Thanks.